Ryan Stanton here with ACEP Frontline and here at Accelerate in San Diego. And we're going to talk a little bit of observation medicine, which is going to be a good topic because I'll frame it here in a minute. So talking with Dr. Meredith Busman, and one of the faculty here for the conference. And you did kind of the focus that we had here is really kind of that overall aspect of observation medicine, because I was just on, before we started recording, on our board of directors for my independent group in Kentucky, and we were talking about observation status and opportunities and the 8 hours and the over midnight. And, you know, with the volumes that we have and the opportunities we have as emergency physicians, if the bed's going to be taken up, is there a way to recoup some of that potential lost cost? So first, give us a little background on yourself, and then we'll kind of dive into the observation medicine.
Yeah, absolutely. So I'm emergency medicine trained as well. But after I did my 3-year residency, there was an opportunity at my shop with my group that I was interested in joining to be a pilot for their new observation medicine fellowship. Mm-hmm. And I had really liked doing observation shifts throughout my residency, and so I decided to give it a go. So I did my fellowship in observation medicine 1 year, really loved it, ended up staying with my group, and I now work in both the ED and in our observation unit, and am the program director for the observation medicine fellowship, as well as I just started as medical director for our 25-bed type 1 observation unit.
All right, so let's dive into that, because some of the different settings of observation, because the system in which I work, we have a couple of different, we have the kind of separate enclosed observation. Mm-hmm. My current emergency department, we just putting patients into observation status when in our department. Kind of give us a little background of some of those kind of different settings of which we have applications of observation status.
Yeah, that's a great question and a really important thing to clarify, because observation can kind of get a bad rap for when it's done poorly. Mm-hmm. And that's what we like to sometimes refer to as the NO-U, the not observation unit, or a type 4 observation unit, where patients are in observation status, but they're scattered throughout a hospital, and they're not being cared for using, specific pathways and protocols. What we do in our type 1 unit, we have all of our observation patients that are on our emergency medicine observation service cohorted into one specific floor, being cared for by the same observation staff day after day, and patients follow a general set of pathways and protocols to make sure that they're getting the highest level evidence of care. And that's where we really see the best outcomes for these patients in terms of reduced length of stay, reduced bounce backs, and big cost savings, not only for the hospital, but for the patients themselves.
So talk about that. You've mentioned the types, the type 1 and type 4. Yeah. Kind of, let's start back there. Kind of describe these different types or tiers of observation units.
Yeah, so unfortunately, a lot of observation patients throughout the country are still being cared for in this type 4 setting. And most often, those patients are not being cared for by emergency physicians. There was a recent study that was looking to see for facilities that had like a official observation unit, 67% of those type 1 closed observation units were being run by emergency physicians. In between, we have patients who are cared for using specific protocols and pathways but still aren't cohorted, or patients that are cohorted but kind of receive indiscriminate care, mm-hmm. More vibe-based care rather than a specific protocol for, say, a workup of a TIA or treatment for COPD exacerbations. What we do on our unit, because we are a closed unit, we have only our ED observation patients there, is we make sure that all those patients get our standard set of protocols for whatever condition or diagnosis they're coming in for.
So how do you, when you create these processes, I remember when I was a resident and early attending University of Kentucky, kept opening up observation units, and they were closed individual units, but then they became overflow for the remainder of the hospital, especially the ICU.
Yeah.
How do you design and create a program that maintains the viability of that as an observation unit as opposed to becoming an inpatient unit or overflow unit?
That's a really good question. And first, it starts with having some serious conversations with your C-suite. The nature of the observation unit is that there will be constant flow throughout the unit. We are constantly accepting and constantly discharging patients, but we will have kind of high tide marks. And then conversely, there will be low tide marks where we have a low census, which can lead the hospital to thinking they can put inpatients there. Oh, they only have 15 patients on their 25-bed unit. What are they doing? It's 2 o'clock in the afternoon. Let's put some of our inpatient boarders there. That's exactly the wrong mentality, because we know that as the ER gets busy later in the day, we are going to see that new upswing, that tidal increase in our patients later in the day in our observation unit. So it's having a really clear discussion with your C-suite to say, we are going to move our patients through constantly. We will have a high census in the morning and we will have a high census in the evening. And when we reach that low tide mark, kind of somewhere in the mid to late afternoon after we've discharged all our patients, you have to leave our beds open, because our patients can't be considered, like patients per day. They need to be patients per bed per day because of the constant flow through, and really being honest with how your unit works and making sure that they respect that, because ultimately you are opening up other hospital beds for your system that can be filled with ED boarders, that can be filled with elective surgeries, that can be filled with sicker or more valuable patients.
And so why does emergency medicine tend to be kind of the best approach? Because I know there's typically some hesitancy among emergency physicians, like I don't do inpatient medicine.
Yeah.
But also the inpatient folks don't do emergency medicine. And so it's kind of like this weird middle ground of why emergency medicine tends to be the best approach in terms of care for these patients.
What I like to tell people is observation is emergency medicine. Emergency medicine is acute, unscheduled care for patients, and we are determining their disposition, right? We are the disposition experts. We're deciding who stays, who goes home, and we're triaging patients. Who's sick, who's not sick. That's exactly the job of the observation medicine physician. We're deciding who stays and who goes home, who's sick, who's not sick. We're just doing it over a longer time frame, because we know we can't always make the best decision with only 3 hours of information. Patients' disease courses are not longitudinal. They may look like they're improving, but then they kind of plateau. That's where the observation unit comes in. It's just giving us as emergency physicians more time to get the right patient to the right place. I would argue that a lot of what we do as emergency physicians is really medicine. And these patients, while they are acute, they're not necessarily complex. I am the first to say that there are some patients that are much better treated by my medicine colleagues, those patients with multiple active chronic comorbidities for whom we all know there is no way that patient will be going home in less than 48 hours. But for patients that come to me and I think there's a realistic chance that they're going to be going home, that is a great patient for me to kind of continue that care that was started in the emergency department and get them to the right disposition.
So let's talk about the, we here as part of Accelerate, and we have the observation medicine, but we also have, reimbursement coding, those types of things. What are the components that need to be in there to ensure the appropriate billing and reimbursement for these? I mean, and especially focusing on emergency departments like mine, where I've got the behavioral health patient that's going to be there 12 to 14 hours, trying to recapture something that's crossing a midnight, all those types of things. What are the components that need to be there that the physicians need to think about, even if you don't have a type 1 separate cohorted unit, that they can do to recoup some of that cost of doing some of this observation status, even if you're not doing the full 48?
Yeah, no, that's a great question. I also work at a regional site where we don't have a dedicated observation unit, but we obviously take care for psychiatric patients with prolonged stays. What our practice is there is we can place those patients into an observation status and keep them on our service, kind of exactly what you're describing. The things that are important is that you have a clear, specific order within your EMR system that says, place in observation or accept to observation medicine, ED observation, it should never say admit, because words have meaning, and once you start saying admit to observation, you're just obscuring everything. Is this patient admitted inpatient? Are they observation? And it'll make it much harder to track those patients, much harder to kind of appropriately delineate who those patients are. So the first and most important thing is you need a timed, dated order that says place in ED observation. You also need to make sure you have an H&P, and it's important that that H&P include your medical decision making, your interpretation of laboratory studies, the risk that this patient could have clinical deterioration. That's why they need observation. Your COPD patient has a risk of, worsening hypoxia, respiratory failure, which you're monitoring for. You want to make sure that you are including that complexity. All of that needs to be in your H&P, but the plan itself can be pretty simple because most of these patients have pretty straightforward plans. Chest pain can be telemetry, serial troponins, consider repeat ECG if change in clinical symptoms, and then your type of stress test. If a patient has other comorbidities such as hypertension or diabetes, it's good to add a line in too, just to, again, explain the complexity of that patient, what you're caring for. And then you should have a discharge summary as well. Most facilities prefer a discharge summary, which can be pretty straightforward, wrap up, what the care was provided for that patient. And the important thing for the discharge summary is making sure you pull through the time and date of when the patient was admitted and the time and date of when the patient was discharged, when that discharge order was placed. In between, it's also best practice to have progress notes in order to capture those middle day billing codes.
Well, yeah, because you can't technically have observation without actually doing observations at some point. We actually talked about that as whether there needed to be, conversations or at least updates within the MDM for our within our same note during that. So what are the time? Let's talk about some of the time requirements involved. Of course, we can do observation that's shorter, but in terms of separate opportunities in terms of RVU, billing and coding and reimbursement, some of those timestamps and what midnight means.
Yeah, this is all insurance-based, and I think for the real specifics, going to the billing and reimbursement coding conference is where you're going to get a lot of value. But making sure that you have a patient who is in observation for a minimum of 8 hours in order to kind of meet basic billing and coding requirements is important. Again, we think in hours. The 2 midnight rule or midnights really only comes into question if a patient is being considered for placement at a subacute nursing facility, a rehab facility, in which a patient has to have an inpatient stay crossing those midnights.
And what we're understanding the 8 hours, and when is that 8 hours? Is it all inclusive, or is it that 8 hours that you have them in observation status?
Yeah, that's important to clarify. So thank you. That is from the time the patient is accepted to the observation unit. So it's good if you have a patient in the ED who you anticipate is going to have a prolonged length of stay, or all of a sudden you just ordered an MRI for, put that patient into observation the moment you know they're going to be hanging out for a while, to make sure that you can kind of capture the full care that you're providing.
Whenever I see one comes in that's, super intoxicated, I go ahead and place them in observation status. It's almost immediately, just because they're going to be there. The metabolizing to sobriety type patient. Yeah. And then after midnight, the opportunity then to have that second day of stay, coding and billing is important. With all that being said, and that there is opportunity here for emergency physicians, if you don't have any type of program, how do we start to build this, to put it together, to start to educate on observation, and then even working with your administration on something more formal?
I think coming to the observation conference here at ACEP can provide you with all of those building blocks in order to know the discussions to have with the C-suite, to prove the value, to learn what metrics are important to aim for, even what size of hospital is kind of ideal, what size of emergency department is ideal for starting an observation unit versus potentially doing a virtual observation unit. But if you really just want a take-home lesson, there are some excellent textbooks, including the one by Sharon Mace, which was just published in its second edition, the emergency or the observation medicine kind of handbook or Bible. It's full of pathways, protocols, everything you need from starting an observation unit to expanding an observation unit, and has a lot of really good resources in there for the literature supporting the use of these units.
Well, the good news is there's still considered the outpatient status, which for most of us from a medical malpractice insurance standpoint falls within our current policies. The thing where it gets difficult and challenging, I always remind people, is that most of as an emergency physician, most of your malpractice does not cover inpatient care because we're not credentialed for inpatient care. And so when you go to the floor, a response has to be a rapid response, an emergent condition, something unscheduled that we can justify in terms of something an emergency physician would have to do. Are there any other nuggets or things like that? Reminder, if you want to come next year, the conference is actually in Orlando. We'll be on the property at Disney. So another opportunity, East Coast, to come down, have a wonderful conference. The weather is much nicer than most of the country is right now, and will be the same for next year. And so that being said, go ahead and get signed up or have that as a plan. But what are some of the other kind of take-home points or nuggets that you would recommend in terms of observation and things that emergency physicians may not be thinking about?
Yeah. Observation is a status. It's not a place. So observation care can happen anywhere. I would say having the observation mindset for a patient that's staying in your emergency department, making sure that you're thinking those 1 to 2 to even 3 extra steps ahead to facilitate that patient's care. Important things for us, which sounds so mundane, but make sure you let the patients eat if they're not going to have a stress test until tomorrow. They don't need to be NPO. They're not going anywhere. Make sure you get patients' home medications reordered. That's really important because we certainly don't want to make any conditions worse. We don't want to have a patient's blood sugar go uncontrolled just because we were treating their back pain in the emergency department for 12 hours. So try to think about just those little things that we are perfectly capable of doing. And making sure that you get medicines reordered, you schedule the antibiotics, you schedule the nebulizer treatments, the antiemetics, you have PRN pain medications. Just do that little extra thing that can start caring for that patient like they're in observation status.
Give us a few things that you've seen. Somebody now that's over a program in the education and that aspect of observation medicine, the things that you see that consistently cause these programs to fail. Like that, sometimes that ready, fire, aim aspect of getting into something and not letting it fully bake before and then failure. Are there things that you see consistently, mistakes that systems, departments, groups make when they're putting in these programs?
I think one, people expect instant results. They expect the moment they open a 30-bed observation unit, there will be 30 patients per day running through that unit. It's unrealistic. You have to train staff, you have to train consultants, you have to train your emergency medicine partners about which patients can come to the observation unit and which ones should be excluded from your unit. So that's step one, because otherwise people are going to say, it's been 3 months and we're only a third full, we're only half full. We're losing money on this unit. What are you doing? So one, it's setting realistic expectations. This takes time, especially if your system is not familiar with observation medicine, and people need to be educated on which patients are appropriate. The second is making sure that your hospital understands that you are you're a loss mitigation strategy, that you're taking patients and you're turning them around to avoid maybe inpatient readmissions or you are actually offloading the workload for your internal medicine colleagues so that they can care for patients who are sicker, maybe carry more RVUs because they're oncology or transplant or their elective surgeries, while you manage those patients who need to be cared for, the patient with a psychiatric emergency, the patient with an asthma exacerbation not taking their meds. They still need to be cared for. They just don't need that inpatient level of care. You can provide a huge cost savings to the hospital, and there are a lot of studies out there showing the expected cost savings per patient based on the size of your unit.
And we talked a little bit about, sometimes hospitals using it as an overflow unit. Going back to the UK, I think by the time I left, we were up to CDU3, and CD1 and 2 were completely full of ICU boarders. And so actually, we're not even a CDU anymore. It wasn't a decision unit. The decision had been made. When you take somebody and transition them from observation to inpatient status, how do we mentioned, them potentially pushing admitted patients into there, but then transitioning those patients out efficiently. How do you work with administration to ensure that when you make that decision that this patient is no longer observation status, they are going to be inpatient at this point, that they potentially don't say, okay, well, they're in a bed, let's just leave them there, and then potentially then growing that contaminating the observation status of an observation unit.
We had a whole discussion yesterday about conversations with the C-suite, and how do you kind of communicate with your hospital leadership? And I think that that's where this comes in, is making sure that you are hearing what your hospital's concerns are, what their goals are for the observation unit, and then trying to align your goals with them. And you need to communicate that your observation unit runs and works effectively only when it can continue to move patients through the unit. Only when it can continue to offload the emergency department, make more room in the ED for the next patient coming in, and show that there will always be a patient to backfill that observation bed, even if it's going to take an hour or two for it to be cleaned. So make sure you have clear discussions with your C-suite to tell them this is how observation works. We need room to prevent these observation beds from being backfilled with boarders, and you will see the benefits down the line as there's better turnover and throughput with the hospital as a whole. Just make sure that you can make that discussion, whether it's using financial metrics, throughput metrics. And then the other thing that can be really helpful is to sit in on utilization management meetings or with any bed coordinators, any of the throughput specialists in your hospital. Talk with them, and then see what their issues are and how you can be part of the solution.
Final question, because now I'm getting my personal interest in this, just in the idea of building programs. But staffing ratios. When we're looking at the emergency department, there's kind of this understanding, just the time involved, that immediate evaluation kind of mindset, soup to nuts, trying to get people out in 3 hours, all that stuff. Nursing tends to be a 4-to-1 ratio. What do you see as kind of that ideal staffing ratios and composite for a unit? The one that's associated with our freestanding ER is managed by a non-physician under the oversight of the ED physician that's in the ED, but they have a very heavy non-physician model. Whereas my group, everything is 1-to-1, if not a higher ratio of physicians, just because we have chosen a very physician-heavy model. When you see these units, kind of what is that? Is there a formula for that observation unit staffing ratio?
Well, non-physicians are key to the success of observation units. That's how our unit runs as well. For nursing ratios, very standard to have usually about a 1-to-4, 1-to-5 nursing ratio during the day, and then sometimes even 1-to-6 at night. You're going to always need a minimum of 2 nurses, even if you have a 4-bed observation unit, because there's always a nurse that's going to be, going on break, need needs to hand over patients. So you're going to need a minimum of 2 nurses. But then that's the typical nursing ratios. Getting into, like APP coverage, you want to kind of heat map where your busy times are. Like I mentioned earlier, that's usually in the morning, usually in the evening. So having maybe a 12-hour coverage over the night with a dedicated observation unit APP who can make sure that patients are, rounded on in the morning and then dispositioned in the evening, with then overnight coverage sometimes can be provided by an APP who's working both in the emergency department and also tucking patients in or there to answer calls, concerns, respond to patients in the observation unit. That can be one staffing model that's very effective for a small unit. Our unit is 25 beds, like I mentioned, so we most days have a dual coverage APP throughout the morning, afternoon, and evening, and a single overnight with 14 hours of physician coverage. And that's quite heavy. That won't work for all systems, but it depends on what your other responsibilities are. For us, our physicians are also providing sedation services throughout the hospital, so we need some extra bandwidth. Some units will find extra work for their APPs or physician staff by, again, maybe starting in the observation unit in the morning, rounding on those patients, which should usually take about 10 minutes per patient for the physician, and then estimate maybe 30 to 50 minutes for the APP, if you're just looking at modeling a coverage model, and then that physician can go start an emergency shift and be available for on-call. Sometimes units will have staff review outpatient results or discharge results, do quality review, or other work, follow-up for patients as well.
How can folks get more information? Of course, we're talking about Accelerate and the observation unit and program, one of the offerings here for Accelerate, one of our 5 or 6 programs that we have involved here. How can folks get more information about the program, or if they have questions for you?
Yeah, so joining the observation medicine section at ACEP is a great start. We meet at every General Assembly. There's a lot of great information on there about protocols, pathways, published literature. I would say that that's a great place to get started.
All right, I appreciate your time, and thanks for joining us here on the Frontline.
Thanks for having me.
All right, as for me, contact me, rstant@acep.org, rstant@acep.org. You can check us out at Everyday Med on X. I also invite you to make sure that you are downloading all of the podcasts. You've subscribed on your favorite player so that you're getting every episode. We continue to expand the channel and options out there, so plenty of great emergency medicine listening. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
Dinger. Quiet place, all alone. Da, da, da.